All right, good afternoon, everyone, and welcome. My name is Catherine Cosin, and I am the Volunteer and Membership Program Manager at Chevy Chase at Home. For those who are not familiar with us, Chevy Chase at Home is part of the nationwide Village movement, in which neighbors get together to help their neighbors age in place. So we help seniors in the Chevy Chase area with volunteer services like rides to medical appointments, changing light bulbs, tech support, friendly visits. We also offer social events and educational programs like this one. To learn more about us and other educational programs that are open to the whole public and not just members, please check out www.chevychaseathome.org. We are so glad that you could join us for the latest installment of our Navigating Life's Journey series, in which we talk about how to navigate your options for different stages of aging. Each program takes place the first Friday of the month at 1 p.m. In today's session, our fantastic panel of experts will examine post-acute care or rehab and long-term care in skilled nursing facilities, and discuss how you can choose the right place for you if you need this care level. I now want to introduce my partners in this series, Angelique Jackson and Kirsten Parsons, who will be moderating the panel today. Angelique Jackson, LPN, is the Manager of Marketing and Business Development at Charles E. Smith Life Communities. She has been a nurse for over 16 years, serving in the areas of post-acute and hospice care. Kirsten Parsons, MS, RDN, CDP, is the Director of Healthcare Sales for Ingleside. Kirsten has worked in senior living for the past 11 years, 4 of which have been with Ingleside. Most recently, Kirsten served as the Independent Living Administrator for Ingleside at Rock Creek. Kirsten started her career in long-term care nursing, so both with relevant experience to today's topic. And as a reminder, again, this is being recorded, so please make sure you are muted except when asking a question. You can also submit questions to the chat at any time, and we will cover them during the Q&A, which will be the last half hour of the program. So Angelique and Kirsten, I turn it over to you.
Thank you so much, Catherine. It has been just wonderful experience to be able to hold these educational events with you. And I just appreciate you giving Angelique and I the opportunity to bring this kind of educational information to your village members and extending that to other villages. So again, I am Kirsten Parsons with Ingleside. I represent our healthcare levels. So this is a topic that is near and dear to me as I work closely with families to identify the right level of care for themselves or their loved one. As Catherine mentioned, I did start out in skilled nursing. So that's something that I understand well and care about so much. And I think as we talk to our panelists and ask them great questions, we'll hear one thing that I just want to clarify as an outset to this conversation. This is a needs-based level of care. And what I mean by that is that this is not a voluntary, I'm looking at retirement options. I elect to go into long-term care or skilled nursing. What we're talking about here is the highest level of care. So if you've been following along over the past 5 or 6 months, as we've done this series, we've talked about independent living, absolutely an elective, retirement option, or we've talked about assisted living, again, some nursing care support there, but again, really an elective level of care. But when we talk about skilled nursing and long-term care, this is really driven by a diagnosis or a care need that our team of panelists here is going to talk more about. And again, it's a regulated level of care. So meaning that this is paid for often, whether it's private pay or Medicare or Medicaid as the payer source. This is a regulated level of care. And so we'll talk more about that today as well to understand it isn't just differing from each community to community. There's some commonality because we're all abiding by similar standards from the same jurisdiction. So we'll talk more about that today, but I just wanted to set that as an outset for our conversation. I want to thank Angelique for her development of these questions and her really helping Catherine and I as we navigate this process to share great information with you. And I want to thank each of our panelists for joining us today. So we do have some great representation. I will just briefly mention who's on our call and then ask that each of you unmute yourselves and introduce yourself, maybe how long you've been with your organization and what your role is. So I just will say we've got Ingleside on the call today. We've got Charles E. Smith, we've got Collingswood Rehab, and we have ProMedica. So please do unmute yourselves and introduce.
Hi, good afternoon. My name is Janelle Onyenamezu. I am a registered nurse as well as a licensed nursing home administrator. I have been in this field for about 13 years, combined director of nursing as well as nursing home administrator experience. And I'm very familiar with post-acute care, acute care, and long-term care. Also, I am representing Marquis Collingswood. I have been with the organization for a total of 4 years, and at Collingswood for almost 2 years. Thank you.
Hi, my name is Jennifer Bunting. I'm with Hebrew Home of Greater Washington. I am the director of admissions. The past 2 years, I've been with Charles E. Smith Life Communities. Prior to that, from 2005 until present, I have been the director of admissions. I have worked and worked in communities within Charles E. Smith with assisted living and independent living.
All right, and I think Yusuf.
Good afternoon. Hi, my name is Yusuf Kennedy. I'm a care transitions nurse with ProMedica, formerly known as Manor Care. I've been with the company over a decade in this capacity, as well as other capacities on the skilled nursing side. Currently, my role was formerly known as a hospital liaison, meeting with the families and the patients bedside in the hospitals prior to coming into the post-acute world. That's pretty much my story.
All right, thanks. So glad to have you all join us. So we're going to jump right in, similar to previous months. Angelique and I will ask questions of our panelists, and then we'll save some time at the end for each of you to either come off mute or to type in the chat your own questions. So again, kind of the level of care that we're talking about today is skilled nursing facility. That's that overarching term that you're going to hear. And then we're going to break down care terms within that you've likely heard if you've had a hospitalization or cared for somebody who's looking for a rehab setting. So, go ahead.
It looks like Mary has joined us. So let's let Mary also introduce herself.
Sure. Mary, we just wrapped up introductions. If you could introduce yourself.
Well, good afternoon, everyone. My name is Mary Savoy. I am the the administrator here at Ingleside at Rock Creek, where we have a skilled nursing facility as well as assisted living and memory support. So I'm happy to join you this afternoon.
Thank you so much, Mary. And good eye, Catherine, paying attention to everybody on the call at once. So Mary and Jay, I'm going to direct this first question to you all. If you could define for us what post-acute and long-term care, what those terms mean, and then what type of services does each offer, and what are the differences in the types of care provided? So again, looking at that term post-acute and long-term care.
Mary, do you want me to go or would you like to go?
Well, why don't you start? I'll fill in.
Okay, sure. Post-acute care, it encompasses the services people typically receive while recovering from an injury, illness, or a surgery. So typically from a hospital stay or some decline at home, and your primary care physician gives you an order for some type of rehabilitation post-acute care. Mm-hmm. This care can occur on either a long or a short-term basis. However, the primary purpose is to assist people to rehabilitate and restore their original functioning. Post-acute facilities can either be freestanding or it can be a larger unit, but in our case, most of us are a larger unit. I'm not sure, Mary, if you also have like an assisted living with your end as well from your admissions or community person. I gather you might have a combination of that, long-term care / post-acute care as well as assisted living.
Yes.
So Post-acute care can include anyone from any age, regardless who requires rehabilitation services. Many acute hospitals have created partnerships with post-acute care facilities to track patients after their transition of care as well, just to base outcomes. So some examples of post-acute care facilities are skilled nursing facilities. Anyone who has received at least 3 days of an inpatient care during an acute care hospital stay can receive skilled nursing services, also known as nursing homes. And the primary care, the primary purpose is to provide continuous care for adults who can no longer live independently to rehab themselves. We also have some independent rehabilitation facilities, some home health care agencies, as well as long-term care hospitals, which are less common.
Yeah,
go ahead.
I was just going to add to your comments, Jay, that the whole notion of post-acute really is very simple to understand. If we think of acute care is being provided in the hospital and post-acute care being provided in a facility once the hospitalization has ended. So certainly, as Jay said, post-acute care does have to be ordered by your physician and to make a determination that indeed there is a need for additional services beyond your hospital stay. And so, and then the post-acute services certainly do vary depending on where you might choose your rehabilitation. Here at Ingleside, our focus of our post-acute care is subacute rehab, and residents come to us from the hospital, and then the focus of their recovery is on rehabilitation, including both speech therapy, physical therapy, as well as occupational therapy. So.
That's such a helpful clarification, Mary. And for those listening in our audience, I just think it would be helpful to understand in steps, if we think about the hospital, that happened as maybe your step 1, and then post-acute as your step 2. It's very possible that the appropriate discharge setting might then be long-term care. So it would not be inappropriate to think of long-term care as maybe a step 3, depending on the care needs. Again, assisted living could be that step 3, or even discharge home, but that might be a helpful way to think about it.
Right. And also just to touch a little bit on long-term care, mostly it's residents 65 and older. However, in 2022, we are also seeing patients who are a lot longer, who are a lot younger, coming in as long-term care residents as well. And, it's just, another place to call home. That person may not be able to care for themselves anymore, or does not have that, supports at home or in the community, and they may opt for long-term care.
Mm-hmm. Yes. Yes. I think you covered that pretty thoroughly, Jay. Thank you.
My pleasure.
Thank you, ladies, so much for that definition. I hope it's clarified a lot of things for our audience today. So my next question is directed to Youssef. And Mary and Jay kind of touched on it with the definition, but could we go more in detail of who is eligible for both post-acute and long-term care services? How do you make that determination? And what is the process of admission to your centers?
Well, pretty much anyone who's been deemed by a physician or an inpatient hospital rehab team as needing post-acute rehab would be medically eligible for an inpatient SNF. Sometimes when there's been a life-changing illness, if you will, like a stroke or something like that, where they're not able to return to their prior level of functioning on their own, in that case, they also would be medically eligible for skilled nursing, things of that nature. Long-term medications, be it antibiotics, things that would require nursing care that they wouldn't be able to manage themselves independently at home, would make them eligible for SNF care. On the financial side, we typically see two types of payers, the insurance payer and the private payer. Insurance can range anywhere from Medicare to any of the various insurances out there. And that all that together ties into how we make our determination and to accepting them into SNF. We look and see what their benefits are, what their benefit offers in comparison to what we're able to offer. And we try to tailor some type of a plan for them. Let's say if it's for long-term IV antibiotics, we would work out through our insurance authorization process, what we call a carve-out, like a separate payment plan for the antibiotics, because they would be more costly than, you know, their typical stay. So those are typically what would make a patient eligible, and typically the types of payers that we see and how the process typically works for admission into the centers. Hope I answered your question.
Thank you. Jenny, do you have anything else to add?
Sure. So like Yusuf said, you know, they're coming into a skilled nursing facility. There are some guidelines that we have to follow when processing someone through the system per se. Our goal is to make sure that not only is your loved one getting the care that they need, but also that it's being covered by their insurance company. When coming in under Medicare, all of the facilities are usually Medicare regulated, so they have to follow Medicare guidelines. If they're under a Advantage plan or under a managed insurance like Aetna or United Healthcare, then the guidelines are going to be a little bit different, and they can tend to structure those guidelines. But like Yusuf said, you know, IV antibiotics, rehab, those are skilled needs. If a person, say, required a feeding tube and was under Medicare, that coverage could be for the complete 100 days. Medicare covers 100 days in an episode in a facility. The first 20 days are paid at 100%. From days 21 through 100, they will still pay, but there's a co-insurance. And that co-insurance right now, and it goes up every year, is $194.50. So usually if you have AARP or a secondary insurance, usually that secondary will pick up the co-insurance. It's a good thing to look into if you were getting a hip replacement or a knee replacement, and you wanted to know if you were going to be able to get that co-insurance paid for. It's a good thing to look into that prior to coming in and receiving the services. You did talk a little bit about, Angelique, in the question, a little bit about long-term care and the determination for long-term care. When you are in a facility and you're getting rehab and you get to a point when we're looking at discharge planning, which discharge planning starts at the day of admission, just so you know how that works. But when we're starting to look at how to safely get you home, if you are requiring 24-hour care and you're not able to provide that, or your family is not able to provide that, then we start looking at the option of long-term care services, whether it's in an assisted living, or it's at home with home services, or it's within the community for long-term care for the nursing home. Hopefully that helps.
Thank you.
So clear, Jenny, but also so much information. So I'm sure we'll get a couple more questions at the end, and also things you might take as follow-up questions after this. To our administrators, I want to ask the next question. What are some of the most common diagnoses that we typically see either in post-acute, so right after a hospitalization, or in long-term care, meaning this is now the appropriate setting long-term for this individual? And what do your two centers specifically offer, or any specialty programs to help manage chronic conditions? So Mary and Jay.
Yeah, I'll start that one. Okay. Here at Ingleside at Rock Creek, we offer, as I hinted earlier, our primary post-acute service is rehabilitation, but that covers such a wide variety of diagnoses. Some of the first ones we might think about would be stroke. We can think about folks who have been treated in the hospital for a very serious infection, sometimes referred to as sepsis. That's a diagnostic term. Septicemia is another one. But the service that they receive in the post-acute setting would then be IV antibiotics. And at some points, those are long-term IV antibiotics. And so, and that would be considered a skilled service. I know we use that term skilled and not skilled a lot, but Medicare helps us to define a skilled service as being required. The provision of the service or the care has to be required in a setting like ours, and provide by professionals who would have to provide that service at least once a day. So that constitutes a skilled service, and the diagnoses that go with that are very broad. We do have people who come to us for what is known as cardiac rehabilitation, because indeed they have been in the hospital for so very, very long. They are very weak. They don't have very much endurance. And so they do need some restorative services or some rehabilitative services in regaining strength and their cardiac functionality. We have, so my point is there's a gamut of skill services that can be provided based on diagnoses. We do offer those. But if we look at the broader scheme of long-term care, one of our very special programs here that we are quite proud of is our memory support program. And the diagnosis that supports the need for that service is dementia or cognitive disability. And so we have those are not skilled services, but they are available in the post-acute environment. And the diagnosis that supports that service is dementia, a variety of Alzheimer's type or other types of dementia.
So, Mary, you have done a really nice job, touching on the various diagnoses that, typically facilities like ours see residents coming in with, which is very similar at Collingswood. We also have, specifically for Collingswood, we do see a lot of COPD patients or just pulmonary patients as well, because we do have several specialty programs, and one of those programs is our pulmonary care specialty program, which we do have two well-known pulmonologists who come into the facility and see those patients and round on them once weekly. We also have a cardiac specialty program for all different types of cardiac patients, including atrial fibrillation, MI, which is like a heart attack or a stroke patient. So they round on those patients once weekly as well. And we have an in-house cardiologist. We also have a very well-known CKD, which is chronic kidney disease. And we also have end-stage renal disease as well, which we do have an in-house hemodialysis unit. So we do have nephrologists on site rounding at least once a week on those patients. We also have a chronic disease management program, which focuses on, palliative care, which is just symptom management and hospice care as well. And lastly, we are expecting our vent unit to be launched in October. October the 1st, we will be having a 20-bed ventilator support piped in unit as well. So thank you.
Youssef or Jenny, do you have anything to add before we move on to the next question about your centers?
I can go ahead. So our community has, so Hebrew Home has over 500 beds in our community for just Hebrew Home alone. We have identified 100 beds right now that are just for the skilled nursing facility and or otherwise known as the post-acute community. So after that, those other units are for long-term care, nursing home services. In our community, however, we also have assisted living and independent living. In our assisted living and our long-term care communities, we also have a memory care components in both communities. So in our assisted living, there is our connections community, which is where if a person has dementia and their loved one, or meaning their husband or wife, would like to be with them, they can move in an apartment and be with their loved one, and they can still receive care. So that is in our Landau Connections community. Our Cohen-Rosen community, which is another assisted living in our community, is very much the same. However, your loved one is unable to move in with them, but it is providing memory care services. And then, of course, our Hebrew Home community, which provides, we do accept patients that have needs in the cardiac area, strokes. We continue to look at other options to provide in the community to help with additional services, take patients that are on IV antibiotics. Certainly, if a person were to need a feeding tube or any other service, hospice services, we do provide those in our community.
Thank you so much. So everyone has done a wonderful job kind of discussing the most common diagnoses we see with a need for post-acute care. But Jenny, what is the benefit? Well, we see that a little bit of going to post-acute care versus going home, because there's also, you can go home with home health after a hospital stay.
That's right. The difference is that home health can provide 2 or 3 days of rehab at home, whereas post-acute provides daily rehab. So depending on your insurance, so under Medicare guidelines, Medicare will cover 5 days of PT, OT, whatever the need is. So if it's if you're coming in receiving physical therapy, occupational therapy, and speech therapy, which would be the maximum amount of time, you can get up to 2 hours, maybe even 3 hours a day, depending on what the need is. But that's going to be 5 days a week under Medicare guidelines. The same with insurance. Usually it's going to be dependent on what the policy looks like, but usually it's the maximum amount is 2 to 3 hours. Now, acute rehab does provide more hours in therapy. So, and you have to qualify for that. But the benefit of coming into the community, especially after a stroke, we talked a lot about strokes today, but especially after a stroke, managing after a stroke is very difficult, and getting into therapy right away is extremely important. Same thing after a hip replacement. The best thing to do is to go into a facility and to utilize, to work with rehab. And it's very hard when you're initially starting. So best thing to do is get involved, get engaged, push yourself during therapy. So the process in recovery goes smoother. At home, it's a longer process. What do you think, Yusuf?
I agree with Jenny 100%. But also I'd like to add a lot of the little things. Coming into a rehab or into a community after being in the hospital, let's say, for example, you've had your knee replaced. And you're trying to make it to the bathroom, or trying to remember where your pills are, or let's say your pain medicine's not working, or preparing your meals, or going to the grocery store, or remembering if there's toilet paper, things of that nature. All of those things can be addressed in the facility. You can talk to your nurse and say, hey, my pain medicine's not working. You don't have to wait for a follow-up appointment with your doctor. If something's going on with your incision, somebody will be able to take a look at it right away, get a physician on the phone, and you can have a change in your course of treatment right away, as opposed to having to wait. So a lot of the small things, you don't have to try to get up and go to the fridge. A lot of little things that would inhibit your recovery. You can have those needs met as an inpatient in a skilled nursing facility or in a community, versus going home, waiting for your specified amount of hours of home care or whatever's allotted to you. I think those things are important.
Thank you. Mary, did you want to add something as well? I thought I saw you beginning.
Yusuf really got really very, very close to the point that I wanted to make. And also the points that Jenny made is that, and we do think a lot about stroke and stroke victims, but not only when we think about the knee replacement, when we think about the person who's learning to really have their nutrition provided through some kind of a tube, we believe strongly that we not only admit the patient from the hospital, we also admit that patient's residents, the family members as residents. And sometimes the emotional support that the family needs to assist the patient through this journey, whatever it is, it may not be as readily available. And we find that families are trying to be strong for the loved one and sometimes are falling apart themselves. And so the relief, the services and the supports that Yusuf and Jenny described are available in a community 24 hours a day. And so if that person does need, something in the middle of the night, or how do we manage my loved one's pain? I've never had to do this before. Or she's just learning to walk again. How much do I baby her and allow her to say, I don't feel like it, as opposed to a therapist pushing her to make as much progress as she can. So I just think that's that perspective in terms of the family constellation, or the residents or the patient's support system, factors into the experience in a community, as well as the physical experience that the individual needs, or the service that that person requires.
Mary, that's a great segue into the next question, because we want to know, who are these other healthcare team members? So when we think about skilled nursing, as the name implies, we think about nursing team members, right? So your registered nurse, or your licensed practical nurse, or your certified nursing assistant, that's who we might think of right off the bat. But for any of our panelists on the call, can you tell us some of those other team members, many of them regulated positions, that are included on that interdisciplinary team? Who are those people? What are those positions that are at the skilled nursing level?
So we have members such as the dietitian. We have recreation as well. Because we also believe that, recreation is a very important part in the healing process, and it is a regulatory requirement as well. We have social workers. Specifically at Collingswood, we also have a case manager on site, which Jenny made a very impressive point and important point in her first question, where she spoke about, discharge planning begins on admission. So we have a case manager who is also an RN, and she does a really nice job with, helping the patient and the family members really make that decision whether or not the patient will be discharged and with what services, as well as if long-term care might be the best viable option or assisted living. So some of the other IDT members at Collingswood. And if anybody else wants to add anything, please go ahead.
Yeah, I'll be very quick.
No, I'm sorry, Mary, go right ahead.
Those are the positions also that we have, with the exception of the case manager, because our skilled nursing neighborhood is very small. But I do want to add that we have in addition to the dietitian and the social worker and the life enrichment team or the recreation team that, as Jay referred, we also have a chaplain. And she is extremely involved with our residents, extremely involved. As part of the transition to our neighborhood from the hospital, and also in those instances for at least for our long-term residents at the end of life. Mm-hmm. And our medical director is absolutely phenomenal. She is very supportive, very involved, and participates in our IDT team meetings. She participates in our risk meetings. She participates in care plan meetings with families. And so we really feel that we have a very well-rounded team focused on meeting the needs of the resident and the family members.
Okay, I'd like to add to it. It's Jenny again. So a couple in all the communities, I know that it is the same, because we do all have physicians and that will be covering the care for your loved one as well. In Charles E. Smith and or Hebrew Home, ours are full-time campus physicians that are in our community. Also rehab. I don't think one of us mentioned rehab, and rehab is a big part of the interdisciplinary team, and in our community at Hebrew Home, we're a Jewish community. However, we do honor other religions, but we do have a Rabbi Dan that oversees our community, and he is too very active. So thank you for reminding me of that, Mary, because I'll tell you, it's an important part of the community for sure.
Yeah, sure.
Mm-hmm. Just to clarify, Jenny, when you say rehab, because we're using that term a lot, she's specifically referring to the physical therapist, occupational therapist, and speech therapist that are on the team. Mm-hmm.
Thank you. And so great job at identifying all the members of the care team that both support and navigate patients and family during a post-acute care stay. But I was wondering, Mary, are there any additional health services available on site beyond the therapy and the case management? And if so, are there additional costs for these services?
We have, we do have pain management here, and we have a pain specialist who works with our residents upon referral. We have a geropsych team that comes in and assesses or evaluates every resident who is admitted and is currently on any kind of antidepressant or any kind of mood stabilizer. And so that team is also available to all of our residents. And we have wound care for those residents who have you know, any kind of pressure ulcer or any kind of skin aberration other than surgical. So those services are available and are, and we have, you know, hearing clinics, we have podiatry, we have those services are also available on site. However, they are billed through the resident's insurance. And in some cases that could be a Medicare benefit, or more often it is a private carrier, as we talked about, you know, some of the other insurers. So there are no or very limited out-of-pocket costs to the residents. The other thing that I do know happens, and there could be an upcharge for this particular, and it's not a service, it's an environmental kind of thing. But I do know that in some facilities, a private room is charged at a different rate. And here, I'm really happy that at Ingleside at Rock Creek, all of our rooms are private rooms or apartments, and there is, you know, one fee for those in our skill setting. So we're pleased that we don't offer any upcharges on the environmental amenities that we also provide.
Thank you so much. Is there any other panelists? Are we missing anything before we move on? It's a great description, Mary.
Yes.
And Mary, I kind of tag on some facilities. I know that Hebrew Home is one of them, have a program through Optum, which is a United Healthcare product. And so that program does you can sign up for it if you have Medicare. And what it does is it provides, if you are a long-term care resident and you need a podiatrist, you need an audiologist, these are things that can be a dentist. These are things that can be available to you. Other communities do provide it in a different way. We just do ours under Optum. So it is an option as well.
Okay, so moving on to our next question, talking about social engagement and program opportunities, the fun stuff. You know, what some of this is included from a regulatory standpoint, right? There's certain things that we want to make sure we're offering because well-being is encompassing of your mental health and your spiritual well-being and your emotional health. So some of this actually is regulated to be included, but then certainly each community has their own culture and their own feel for how they incorporate this. So maybe Yusuf and Jenny, if you want to start us off, and then of course, you know, Mary and Jay to answer as well, if you could just tell us about programming and socialization in the community.
Sure. At ProMedica, at our centers, we have certified recreational therapists who formulate month-long programs, if you will, with different recreational activities appropriate to the patient or resident's level of engagement. For our dementia units and dementia patients, they have specific programs relatable to their physical and mental functioning. A lot of it involves traditional things like, you know, bingo, group things like movies, outings, things of that nature. But a lot of things to the more skilled patient coming directly into the facility are geared to like bedside things, things that are appropriate to engaging them with therapy, maybe some fine motor things, or, you know, we try to work with the therapy department to make a segue into their recreation to coincide with their therapy goals for the short-term patient. For the long-term patient, it's more of a, you know, a long-term ongoing, you know, Tuesday night, movie night, Wednesday, bingo day, but we have, you know, recreational therapists who formulate these elaborate plans for our residents for various recreational things.
That's similar in a lot of the facilities, and it's wonderful. And I know that each facility also has religious programming as well. So they might have church services in our community. They have Shabbat services for the Jewish community, as well as Christian services for those that celebrate in Catholic churches or in Christian churches. And in our community, there's also music and art programs, book clubs. These are all things that I think, each of the communities try to represent and bring to the table to help people during their stay. We want their stay to be, we want them to be comfortable. We want them to engage with others, to help their process with getting back into the community to go well. And it helps to develop, sometimes when you're going through a change in life situation, when it's a surgery or, or some sort of an illness that you're trying to overcome, sometimes depression comes into play. And these engagements help them to process and kind of get back into life on life's terms, and helps bring people out into the community. That's all I have.
Well, you're right. I think that it is important to be able to, first of all, we meet our residents where they are. And we try to have as many, as large an arsenal, if you will, of life enrichment activities, so that we can try to fit our residents to what's available, or we may have to develop something else. We coined the term enriching moments to support our life enrichment themes. And we are really, some of our residents just have what we call individual visits in their rooms or apartments, because that is satisfying. That is, they want that daily touch, or that twice a week, no knowledge that they will have a friendly visitor. We also utilize volunteers. And a huge plus for us at Rock Creek is the fact that we are a part of a larger independent living community. And so our independent residents who live in their own apartments, separate from our residents in skilled nursing or assisted living, but they are very active in our building and provide a lot of the volunteer support. We do have, as I think Yusuf mentioned, the art therapy, the music therapy, and not only music for enjoyment purposes, but with a therapeutic overlay, so that it does work with the residents' care plan. We offer fitness programs. We have concert series, again, as part of our larger community, but certainly available to residents in our skilled nursing neighborhood. We have one activity, so to speak, that I think historically or traditionally has been referred to as the daily news or something like that. And so we call that chronicles. We call it daily chronicles. And part of the chronicling is not only what is happening in the newspaper, but what's happening with our residents. Some of our families, have some very interesting information to share. And we've tried to fine tune that into a happening, so it's kind of reported on with the residents. And so it's a matter of trying to facilitate as much normalcy as possible, but also to fill those empty moments between therapy or physician appointments, or meeting with the social worker. There's still some joie de vivre there that we can we can certainly encourage our residents to participate in. So with bridge clubs, puzzle competitions, movies, anything,
Mhm.
you know, to try to make it as an enjoyable experience as possible.
Thank you, Mary. I think you said it wonderfully. Just
Yes.
in between, you know, we kind of think of post-acute long-term care medical focused, but it's nice to know that, you know, meeting your patients and residents' social and emotional needs is very important as well. So,
Angelique, one thing I wanted to touch on as well, in terms of social engagement at Collingswood, is our fine dining program. And this is an awesome way for our residents to socialize. So we do have a very nice fine dining program with chef demonstration as well, that happens, you know, live for the residents. And that's one of our things that we are very proud of at Collingswood as well.
wow, fine dining,
Yes.
cooking demonstrations to help them maybe make healthier choices.
Yes, and we're working
rehab.
on creating a YouTube channel for it, with totally resident focused and resident driven.
Fun. So Jay, I'm going to ask you to begin our next questions to start off, kind of pivoting a little, really asking, how did the pandemic change the way post-acute and long-term care facilities deliver care, and what processes are in place to reduce the transmission of COVID-19?
Okay. So, you know, everyone is going to have, you know, a story here, but, you know, just to keep it, you know, brief and within our time frame here, you know, the pandemic has changed the entire healthcare arena, especially in long-term care, because we are so highly regulated. You know, we have a screening process that everyone goes through when they come into the facility, where there are a series of questions that needs to be answered. We collect vaccination status from everyone. Visitation, you know, we are still, we are open up to visitation now. However, everyone still needs to wear a mask. We are still social distancing as well. Our staff is 100% vaccinated, as well as our residents are 100% vaccinated. We are also working on booster clinics as well. And we are following the CDC guidance, as you know, everyone at this conference right now, I'm sure we are all following, you know, exactly what the CDC says. We have a heavy focus on the booster clinics right now, getting everyone boosted and up to date. If a resident comes in and does not have a booster, that resident will go into observation for 10 days in a private room without a roommate. And pretty much that's it, you know, hand sanitizing, you know, hand washing, constant education, for visitors and staff. We also have a voice friend system, which is a robocall system that we send out message and various education topics at least twice a week. And, you know, that's pretty much what we are doing. Do you have anything to add, Mary?
Well, we're doing, I think you named everything. One of the things that I think came front and center at the height of the pandemic was this whole telehealth visits from the physicians, and some of that is still, you know, residual right now. And also to our life enrichment team did and still does a wonderful job with, you know, video chats and virtual viewing and communications. At the height of the pandemic, again, we had to use those mechanisms to do our care meetings, our care plan meetings, our discharge planning. At some points, We even used virtual training, caregiver training for those residents who were being discharged home, and their loved ones would have some responsibilities for their care once they were, back in their home environment, and the family member or the caregiver really needed to be trained in various techniques to transfer or to get someone in and out of a car or to, assist them to the toilet. And that had to be done virtually. So I think that, and as I said, some of that residual still exists. We never completely, with this last wave, we never really completely closed a visitation. However, we did ask our guests to honor the hand washing, and and the use of hand sanitizers and the masks. And we did ask that they limited the visitation to not more than 2 visitors at one time. So the pandemic just made a huge difference in how we operated. But I think you hit on most of them, Jay.
All right, thank you both. So one of the things that we want to talk about, I think it would just be informative as we think about, again, post-acute, and that being maybe step 2 from a hospital. What is the typical length of stay for a patient coming into that post-acute care setting? And then maybe if we can talk a little bit about how discharge is determined. So again, whether that discharge is to long-term care or to assisted living or to home with a caregiver. How is discharge determined? And then who is involved in that process to ensure a safe discharge from the post-acute setting? So Youssef and Jenny, if you want to start us off.
Sure. So again, like Jay mentioned, discharge begins at admission. So once the patient admits, we have an interdisciplinary team. Everybody comes together. We do the care planning. You have your dietitian, your rehab director, your recreation activities person, and we go over everything. We go over the patient's prior level of functioning to see that we're meeting that, or that we're on target to meet that. The typical length of stay right now for our average Medicare rehab patient is roughly 2 weeks, 14 days. There's gives and takes. It depends on various factors. Everybody's not in the same medical situation. But the typical length of stay is roughly 14 days. For the discharge process, once we get close to the discharge, we talk with the family. The social worker is heavily involved in scheduling things that are going to occur outpatient, like the home care, the community involvement, be it Meals on Wheels, or if they now have Metro Access, or things that are going to benefit the patient in the community after discharge from the SNF. So the social worker is heavily involved. The nursing team is involved, excuse me, in a lot of communication and teaching with the family for things that the patient may need when they go home, be it diabetic teaching, or if it's somebody with a new tube feeding or something like that, and there's treatments that they're going to need at home. Nursing would be involved in teaching, but mostly I would say social work. A rehab team has a big part in keeping them on track and following up with whatever data communication we need to share with whatever home services we'll have. But social work plays, I want to say, that the heaviest part in the discharge planning for the care needs at home.
And I'd like to add to that, Youssef. When you were talking about how long, I like to emphasize that Medicare, again, when going in under Medicare, you have a 100-day plan. Most people don't utilize that 100-day plan, and that when you're coming into a facility to get rehab, that it's an independent care plan. So it's going to really depend on how much needs you have. So if you come in there, and we've used stroke a lot today, But if you go in there with a stroke, 2 weeks may not be enough time. And under Medicare, it may be able to provide you the amount of time that you need. However, under managed care, if you're coming in under a managed Medicare, a managed care, an Advantage plan, they do dictate the amount of time that you'll be in the facility. They are the ones to, based on the conversations that they have with us, and when you reach what they call, what in their baseline, they are helping to manage the time in the facility. So that might be, they may say, okay, at this point, you're ready to go home. Our team has a little bit more leeway. We work under Medicare guidelines, and we try to establish those guidelines to help get you home safely. And so it's important to us to make sure that that process goes smoothly. And we have a little bit more leeway under standard Medicare. But I just wanted to make sure we added that.
Yeah, I think that does help cover that length of stay piece, Jenny, because it does depend. And our average length of stay here at Ingleside at Rock Creek is about 3 weeks, but we have folks here, you know, in some cases for as short-term rehab residents for as long as 6 weeks. It depends on the need. And it also depends in some cases on the rate of recovery or the progress that the resident actually makes. If it seems, because what we have to keep in mind is that in short-term rehab or in the subacute setting or skilled nursing setting, generally the insurer is helping to foot that bill. And in the case of Medicare, they really want to know that the stay is beneficial, because it's fairly expensive under your insurance plan. And so if it's not beneficial, meaning if the resident is not making progress, then the therapy team, in our case here, the therapy team would say, we're not seeing any progress and we can't justify continuing the treatment. And so then we start working, you know, even more diligently toward a discharge date. And as Yusef said, you know, the discharge planning starts at the very beginning of the stay. And so the resident and the treatment team, usually the therapy team, start to identify goals that, based on therapy's experience and expertise, the resident should be able to meet. And so they're working toward those goals, those 7 days or 14 days or whatever it is. But if it seems that those goals are too lofty, or that the resident, you know, sometimes folks give up and they just don't want to participate, then therapy has to say, we cannot justify this stay or many more days. We can justify another 5 days, but we've got to see more progress, because Medicare scrutinizes those claims and they look to see that there is progress during the stay. So those factors do contribute a lot to the length of stay and the services that the resident receives.
Thank you. Great points. And since while we are on the topic of discharge, what would make discharging home no longer a safe option? And you guys did mention a little bit about how you determine the discharge, but would it be safe to say someone who is not safe to discharge home, would they be eligible for long-term care? Jenny, if you wanted to start us out with this.
Sure. Not everyone is eligible for long-term care. There's a part of the process in which needs to happen. So if a person were to come in receiving rehab, going through the process of rehab, that requires 24-hour supervision, then comes in and we look at all parts to the process. And so it's going to be medically as well as financially. So it's possible that a person is, because long-term care in a nursing home can be expensive. And so financially, we look at the financial part to see if they're financially able to meet the guidelines under long-term care first of all. And then if they financially are able to afford it, and if they can't afford it, we look at an option under Medicaid to see if we might be able to help them and guide them through the application of Medicaid. So there's also guidelines under Medicaid in order to see if you're a long-term care appropriate for a nursing home, or you may be appropriate for an assisted living. So with additional assistance.
Yusuf, does anybody else from the panel have anything to add?
Sometimes, I know on the SNF level, we find unsafe discharges in various situations. Sometimes it's family support. Sometimes there's situations where we'll have someone come in after a fall with a hip and we can't get in touch with anybody, or we don't have family participation for cooperation with the Medicaid process. Or sometimes people come into us with APS involved, or different social determinants that would make it unsafe for them to return home. In that instance, we, involve social work and reach out to the various, community entities that are available to, assist that person in whatever way we can. But there are, sometimes social issues that make a discharge unsafe as well.
Mm-hmm. That's a very good point, Yusuf.
Mm-hmm. Yeah.
All right, so I know we're wrapping up. Just two more questions before we open it up to the audience for questions. And Jenny, you've kind of danced all over this already in terms of cost for post-acute care or long-term care. So I think we can probably be pretty brief here, but maybe if Mary and Jenny and Yusuf, if you can touch, and Jay, as you as well, if you can touch on the private pay cost for long-term care. So again, if post-acute, you're going to end up staying in long-term care, maybe what that cost looks like. And then also, Jenny, you've mentioned Medicaid, what that cost looks like for specifically staying in this setting.
Our costs here at Ingleside at Rock Creek for long-term care private pay is just under $600 a day. We're about, I think we're at $550, $560 a day for cost here.
At Collingswood, our cost for a semi-private room ranges from $320 to $350 a day, and private rooms $350 to $400 per day. And we do have a special program where someone might just need a 10-day rehab stay. We do offer a discounted rate of $250 a day. And the maximum we can do that for is 10 days. And it's called urgent SNF. We also work with the VA for long-term care. So if one of our veterans come in skilled and they are 100% service connected, we will be able to work with the VA to obtain a long-term care contract. So quite a few veterans, we have at least 25 veterans right now who are on long-term care VA, which is an amazing benefit that the VA extends for those veterans who are 100% service connected.
At Heber Home, we range between $420 and $500 a day. And you brought up a good point, Jay, with regards to people may not be a veteran, but they might have been paying into the long-term care, into a long-term care benefit. The long-term care benefit does pay for long-term care services in a nursing home. You may want to look at your benefit if you have been paying for that for years, because the benefit sometimes will pay out per day, or they'll give you a lump sum and pay out the lump sum, and you can pay for that for a period of time.
For ProMedica, it's probably a little different. We have 5 facilities in the Montgomery County area, and our private pay is somewhat tailored individually. We ask that families make an upfront deposit of $10,000 for the first month, and we do carve outs. We break it all down, decide their meals, if they're going to need incontinence briefs or tube feeds. So each facility has a different per day price, if you will, but our private pay process is very detailed. So we often come out with a different number for each family, but it's based on a per month basis. If they were to leave prior to the end of the month, we refund them. But that's how our private pay system traditionally works.
Thank you. Thank you so much to the panel for giving our audience an idea of the costs associated with long-term care and post-acute care. And then my final question before we open it up to the audience, and it's going to direct it towards Yusuf and Jenny, because Yusuf, you work at the hospital level, you see the patient before they come into the center. And Jenny, I'm sure as the admissions director, you do a lot of guidance before they admit as well. So my final question is, how would you guide someone through the process of choosing an appropriate post-acute or long-term care facility that would fit their needs? And what questions should they be asking when touring?
From my perspective, I think it's important to really research or to ask whoever you're communicating with as you're considering placing your loved one in a facility. Ask for data like outcomes, Medicare star rating, pertinent physical material that's related to your condition. Like if you have a knee replaced, you want, of course, someone who has great experience with orthopedics, or whoever your ortho surgeon may recommend, or something like that. I like to talk to my families or compare the SNF situation to daycare. You have your child, you really, care for your child so much. It's a very emotional decision to make. And you want to send them to the best place, a place where you can drop them off and have peace of mind. So that's what, I encourage families and patients to do, to really do their research, investigate, look at what facilities maybe specialize in whatever their specific situation is, because everyone's medical situation is different, and go from there. But ask for physical data related to the facility and what it is, what services it is that they're offering your local.
So I'll tag onto that, Yusuf. To add to what Yusuf was saying with regards to the star rating, you can go to Medicare.gov to look at people's star ratings. They also are, they usually get an annual assessment. It allows you to take a look at what that looks like. And each community does provide that at their front desk. So you should be able to see those things when you come into the community. When I'm touring people and I'm talking about our community, the first thing I do is ask where your family member is, if they're at home or in the hospital, and what you feel they may need, because a big part of this is we're working to help your family member as a team. So the family and their interdisciplinary team want to make the best choice possible for your family member. And we want you to feel like you can trust our knowledge of what we have to offer. And we want to provide you with the best information so you can make a good determination and good choice for your family member. You know, sometimes in family members' eyes, because they're caring for their loved one at home and it's hard, we know that they may come in feeling like the need is for, I need for them to go long-term care, but they may be in an assisted living level. And so we try to help you process that and walk you through that, and so you can see what that looks like. We help to guide you. That's what our job is. Our responsibility is to help you see how our community can help you. And we try to provide you with all the resources that we can. So the questions that we might ask you is, what is your loved one able to do for themselves? And that is removing you from the equation. So what can they do? Can they take their own medication? Can they feed themselves? Can they cook for themselves? Those are the types of questions that we would be asking to help you through the process. Your questions to us would be, would you be able to provide those services for my loved one? And where and what community would be best fit for my loved one? So that's how the process works. It's trying to figure out what's in the best. So we would be working as a team together to help make those determinations for your loved one.
All right. Well, thank you so much to our panelists for sharing so many details and information. And I know to our audience that it was a lot of information to take in, but we thought it was good for you to get a sense of all the different kind of models out there and to get a better picture of what life would be like, you know, everything offered at these different kinds of facilities, you know, so that if you are in the situation or your loved one's in the situation where you need skilled nursing, long-term care, or, you know, short-term post-acute care, you have a better idea of that. So we did have a few questions. And actually Jenny was kind enough to answer some of those questions. So I'm going to read her answers too, and see if anyone else wants to weigh in. So someone wanted to clarify, earlier Jenny was talking about the co-insurance. Was it $194 a day co-insurance? And she said, yes, that is for days 21 to 100. You get Medicare, $194.50 co-insurance. Someone also asked about what category would a Parkinson's patient fit into? Is care for them a skilled service? And Jenny said that Parkinson's alone is not a skilled service, but if there is a physical decline, it is important to be evaluated. And then, someone asked, at Collingswood and ProMedica, for example, what is the waiting time to get in these days?
So for Collingswood, we have a very quick review and turnaround process. So, you know, it's as quickly as within a day or sooner if we can get all the information that we need. But we will have an admission decision within 15 minutes for the most part of it. Okay,
and Yusuf, is it similar, like where there's not, because we know that with like independent living and assisted living, there's often a waiting list and stuff. So I guess the question is that a common thing in skilled nursing?
It's common. It's fairly consistent. For us at ProMedica, we're not as good as you guys over at Collingswood. We don't do it in typically 15 minutes. It takes us maybe 30 minutes to an hour, to be quite honest. But it's about the same process, yes.
Okay, so it's not, you don't have to worry as much about like a long wait kind of thing for skilled nursing facilities. And then someone asked, if one lives in a facility that has only independent and assisted living, what would be the process for getting skilled nursing care if needed? And someone, Jenny said, home health can visit independent and assisted living facilities. And that, for example, Charles E. Smith can provide the assessment for rehab in both communities. So I guess they're suggesting that you would, if you don't have nursing facilities on site, skilled nursing, maybe you could get home health aides to come if you didn't want to leave to go to a different facility. Any other answers from our panel on that one?
Well, you know, it boils down to if the person does not want to leave their current environment. If they do want to leave their current environment and they had some sort of debilitation, it would require a visit with their primary care physician with an order to be admitted to skilled services.
Okay. Someone also asked, is the Medicare 100 days a lifetime limit? And Jenny said that if you have a 60-day break from a hospital or rehab center, the 100 days starts over. So it is not a lifetime limit, the 100 days. You just need some breaks there. And someone wanted to clarify what SNF meant. So I will say for those watching the recording, it's Skilled Nursing Facility, just an acronym, SNF. With, I don't have your name, but in the Neil Davidson frame, I think, did you have your hand up for a question, Miss?
A couple of questions. One is that we have long-term care insurance right now with Genworth, and every couple of years they jack up the premiums mercilessly, and we have to decide, can we afford to keep this insurance? And I wonder, what might you folks have to say about that? Is it worth paying the enormous premium increases, or should we just give it up and take the one-time payment option?
Catherine, can I jump in and I'll defer to anyone else? I would say please keep it. These are such expensive levels of care. I work specifically in our assisted living, and long-term care insurance can make all of the difference for getting into a community that has excellent standards and you want to be a part of. And when you have lesser options, or you're saying, you know what, I don't have the resources to privately pay, long-term care insurance makes all the difference in the world. So if you've already been paying into this plan, I think you've done a good investment.
Okay, thank you.
All right, any other questions?
Catherine, I want to just also address the question about living in a community that doesn't have skilled nursing facilities on site. And I think if you or your loved one already has a diagnosis, I would say A, that's progressive, or B, that you have already experienced being maybe in and out of the hospital, to maybe be thoughtful if you're looking at retirement communities to a life plan model or something that has skilled nursing on site. Because if you're part of that model, then when you live in independent living or assisted living and you need rehab, you can do that right there on campus. And same with long-term care. So not everybody's needs are the same, but if that's already a need that you know you or your loved one already has, that might be a thoughtful part of that touring process.
I also wanted to backtrack, because I know Collingswood and ProMedica, when you were talking about time frame in which to go into the facility, that is for skilled nursing services. The time frame and the response time for skilled nursing services. When you're looking for long-term care, it might take a little bit longer, just so people understand that.
Correct.
Okay, so that was for more post-acute care.
Mm-hmm.
Got it.
Yes.
Okay.
For long-term care, because we need to, review finances, we will need to do a financial screen, etc. It does take a little bit longer, unless, someone wants to come and pay private pay immediately, and, that can change things.
Okay. Can you clarify when you say longer, like, can you give an idea of what
long-term, like living in the long-term care space? So someone is coming in to be a resident at Collingswood permanently.
Yeah, I meant like when you say it takes longer, is that like more like a week, or I guess
it all depends. There are various factors, cooperation from the client as well as their family members, if their family members are involved. The business office, manager needs to do various types of, financial screening. Bank statements may need to be involved, asset searches, stuff like that. So it varies.
The other thing I just want to throw into to add to that that's very important is bed availability, because there may not be,
right.
Long-term care implies, as you said, the person comes to live with us for the rest of their lives. And if there is no availability, we're technically waiting until one of our long-term residents expires before there's an opening.
Okay, yeah. So I guess do you have an average of, if this is a concern with someone, like what they can expect, especially recently? I know the pandemic has affected staffing and might have caused more issues with that, or?
I know with Hebrew Home, when you're looking at the clinical, because you have to do a clinical evaluation and assessment, as well as a financial assessment. If families were able to get the financial information that's needed right away when they're doing the application, and they're able to provide the clinical information, at that point, it can happen in a week's time where you can get someone in long-term care. If you were to do beyond, if you were looking at Medicaid, the other part of the process is that you have to get Medicaid there's a form that needs to be completed through Medicaid. It's called a 3871B, just so you know, and that needs to be completed by your physician. And then that gets submitted to the state, and then a level to request to see if that level of care is appropriate for your family member. Mm-hmm. So there's a process, and I think in every community, if you get all that information a week right up front, then a week's not a bad amount of time. But if you're giving them piecemealing the information, it really is going to be dependent on when you get the information. And then also, if we're looking at Medicaid, the submission of the Medicaid level of care.
Okay, thanks for the clarification there. Any other questions from the audience?
Well, I had one more, and it has to do with a definition of memory care. We have a couple of friends who are in memory care. Their memory is gone. It's hopeless. They don't recognize their spouses or their children when they come in, and their memory is not going to improve. So could you say a little bit more about what's meant by the definition of memory care?
Catherine, I can jump in and then I'll defer to any of our other team members. Neil, I work with Ingleside at Rock Creek, and I represent the other two Ingleside communities. So I can just share about our model, and then also that term, which I agree with you, could not be more confusing. And I'll tell you another reason why it's confusing is that memory care neighborhoods can be at the assisted living level of care. We talked about that last month, or it can be at the skilled nursing facility level. And so that means that the individual's nursing needs are different, nothing to do with their memory care needs. And so that's one part that's confusing. Some of your friends may live in an assisted living, some may live in skilled nursing, and that term memory care is used for both. So that's very confusing just right off the bat. So I agree with you. When we talk about memory support at Ingleside, that is at the assisted living level of care, meaning that somebody's neurocognitive changes have not progressed so far that they're not recognizing loved ones. This really is a season where we can support them still. A lot of engaging programming, facilitating those family visits. So it's more of a support model. And then our care level is at the skilled nursing level. So really at the time, as you mentioned, somebody's no longer recognizing loved ones. They really aren't able to participate that much in their own care needs, and we're totally caring for them. That would be memory care. So that's how Ingleside defines it, because it is really confusing. But that's a great question. I think it's, like I said, confusing because the term is not clear.
Okay, thank you. Okay, that's helpful.
All right, and I just am just dropped in the chat the link from the memory from last month, if you didn't have a chance to attend, where we talked a little bit more about memory care at the assisted living level. All right, any other questions? I did just put in the chat. I will send out also the link to the previous recordings to everyone who registered, along with this recording that will come out sometime next week, and also the contact members for our panelists, and also the link to register. If you're interested, to our next panel is going to be about, I guess, the final stage of life's journey, hospice care, death with dignity, and grief support. So it's not the most, it's a bit of a depressing topic maybe, but an important one to feel. So we're gonna have that next month. Thank you so much to everyone who attended this month. We're so glad that you could take the time on this sunny afternoon, talk about this important topic as well. And thank you so much to the panelists as well for sharing all of your expertise and time. So have a good rest of your afternoon, everyone, and look out for my email next week. Thanks again.